the history and future of compassion in healthcare. My name is Shahla Siddiqui. I'm an assistant professor in the Department of Anesthesia and Critical Care at Beth Israel Deaconess Medical Center. Compassion is a ubiquitous term in healthcare. However, there haven't been many references towards compassion until 2015 in literature. In this picture, you can see a physician sitting at the bedside of a dying pediatric patient. It's called The Doctor, painted by Samuel Fildus, and it's hanging in the Tate Museum from 1891. This painting depicts the compassion, the empathy, and the presence of a physician sitting next to a patient immersed in their suffering. You can see the parents distraught in the background, looking reverently at the physician. And this painting depicts everything that embodied a physician and how they functioned at that time, the time that they would give the patient and the presence that they would show the patient and their family at that time. The word compassion is ubiquitous in modern healthcare, yet few writers agree on what the term means and what makes it an essential trait. Although many modern writers have assumed that compassion is a universal and unchanging trait, the term is extremely new to healthcare, only becoming widely used in 2009. The concept could have previously existed under another name. You can see in this slide, this is a mural of different ages and different times in history where you can see physicians and healers taking care of patients who are suffering. And they're showing compassion in their own way. You can see Indian Ayurvedic medicine, you can see the Chinese traditional medicine, you can see the Romans and the Greek, as well as the Muslim healers at that time. This is ancient history. I will thus present in this talk a historical approach to understanding compassion, as well as weave several influences of moral and ethical philosophies. I will end with how compassion is pivotal for the future of medicine and healthcare, and where my research stands in this construct. We do know that religion has complemented medicine in similar ways in many cultures and in nearly every age. Compassion and humanity are the basis of this intersection. Even today, many people view medical concepts and treatments from a religious perspective. This book was written in the 1800s by Gary Ferngren, and he talks about medicine and religion and having some sort of a common pathway and a historical introduction to this pathway. Ayurvedic tradition from the 800 BCE talked about how you should feel someone suffering. You actively engage in your own sensitivities, nervous system, and emotions in mimicking the feelings of one who is suffering. And this actually describes what is now known as empathy. Avicenna or Ibn Sina in 980 AD was an ancient father of medicine in the Islamic tradition. He described purity of body and mind through compassion and justice. The Greeks and Romans, for example, Homer and Hippocrates in 750 BCE, talked about concepts of divine retribution and the need for morality and empathy as a means for purification. Also, the traditional Chinese medicine from Su Wen in 206 BCE talks about the spirit which is being responsible for benevolence, which is loving kindness, awareness of suffering, empathy, compassion, and tolerance, and serves as a reservoir for ideas that bring meaning into life. The influence of religion and spirituality in medicine goes back a long way. Compassion embodies the phase of character that is grounded in human dignity or respect for persons. This was the moral basis of many religious philosophies, as well as grounds for the work of German philosopher and ethicist Immanuel Kant. One of the most important work of Kant is the central philosophical concept of the categorical imperative, which links deontological morality with unselfishness and compassion. Our capacity to reach out beyond ourselves into the lives of others allows us to work together for a common good and forms the basis for human success. It is a moral imperative to reduce the suffering of others and not cause them harm, which is the basis of the Hippocratic Oath in medicine as well. Here you can see how compassion intersects morality and is the basis of morality. And this was also underlined by this author, Arthur Schopenhauer. Compassion is similar to emotions, but it is different. It's simply led by emotions, such as in empathy and sympathy, and has a problem of being biased and visceral and prone to fatigue. So if you lead your compassion just by how you feel and get involved emotionally in a situation, this could be prone to bias. When compassion is combined with morality, we then have a duty towards others. And now we have to do what is right, despite our emotions and ourselves, which values and respects their humanity and transcends just emotions, which can be biased. Becoming compassionate, and here is a new model for healthcare in the 21st century. There were few references to compassion before the 21st century, but then a sharp rise this use occurred in 2013, the year Compassion in Practice was launched. This was a report called the Francis Report, published in England in Mid Stratfordshire National Health Service Foundation Trust. And this report actually talked about how an entire hospital trust was lacking compassion and lacking humanity. They did this audit on a hospital system, and they found that there was an immense amount of people who were patients who were just left in their own feces, and they weren't taken care of, and humanity was lacking. And the Francis Report underlined how there was a lack of compassion in healthcare. And the centrality of compassion in healthcare, based on recommendations of this report, were then made common to all NHS trusts. References have sharply risen since 2015 in medicine, since the Francis Report came out internationally. And today the word compassion remains a little overused, but little understood as well. If we are to continue to employ it at all, we need to be aware of the concept historically, socially, and politically, and avoid using it to draw assumptions about the moral character of the individual clinician, but of the action taken based on duty and virtue. This is a book written by Lauren Berland, and this talks about culture and politics of an emotion, and it's called Compassion. It's important to be present when you are dealing with another human being, or you're in a situation where your interaction with another human being. This presence is different from understanding the personality. It's infinite, it's unbound by anything. It's open, spacious, silent, and forever aware. So you have to be aware of where you are, what's happening, and this requires a certain amount of emotional intelligence. In this article in the BMJ Open 2019, the author writes about the clinician presence and the importance of presence. Clinician presence is best enacted through purposeful intention to connect, conscious navigation of time, and proactive management of technology and the environment to focus attention on the patient. Everyday practice or ritual supporting these strategies could support physician self-care as well as physician-patient connection. So here, the emotional connection or the presence of a physician underlines their own self-care as well, and their own well-being and a feeling of purpose. Compassion has two aspects to it, the yin and the yang, using caring force to change ourselves and the world around us. The yin begins with ourselves. That means you have to be comfortable, you have to be comforting, soothing, validating, and the yang is towards the outside world, which is protecting, providing, and motivating. The research that we do in our center here at Beth Israel and in the Sadhguru Center is focused around three aspects of compassion: compassion for our patients, compassion for our peers, and what is hindering compassion within ourselves. And now I'll talk a little bit about the future of compassionate care, especially in the ICU where I work. This book, The Soul of Care by Arthur Kleinman, is contemporary, and it's talking about the moral education of physicians. He talks about the contemporary crisis of caring, and globally is implicating the soul, implying medicine and healthcare has become soulless. They fail to engage the most deeply human experiences that require care, not management. We need soul to specify the human quality at the heart of care in order to animate the souls of patients, family members, and clinicians. In this study, which we are conducting with Dr. Arthur Kleinman as the senior author, we're looking at compassionate care in the ICU, and this is funded by the John Hedley White Grant from Harvard Medical School, and it's sponsored by the Sadhguru Center for a Conscious Planet. We're using the knowledge to understand compassionate care in the ICU through a multi-method observational study, a survey of ICU physician members of Society of Critical Care Medicine in the US and the European Society of Intensive Care Medicine is being used. And the aims are to modify this version of the Schwartz Compassionate Care Scale for self-assessment by physicians, and then to assess a broader understanding by eliciting free text comments on 3 ICU case vignettes. A focus group discussion is then conducted to get from a few volunteers to discuss background determinants of lack of compassion, such as systemic bias, etc. And we're using videos that we have made to show compassionate care versus non-compassionate care. The survey is using the Schwartz Center Compassionate Care Scale. We have free text replies in 3 case vignettes, and then focus group discussions. The flow of the study is that the cases are presented to the participants. We use qualitative analysis with focused questions, and then have a discussion with 3 different focus groups and form a theory on understanding of compassionate care in the ICU. The second study that we are conducting is using compassionate care within peers and forging interprofessional education in the perioperative setting. And this is during the COVID pandemic. It's using emotional intelligence tools to navigate difficult situations, and this study is under the funding of the Healthcare Delivery Sciences. The aim is to develop an interprofessional curriculum consisting of case-based discussion for anesthesia and surgery trainees as well as nurses. The second aim is to improve awareness of emotional intelligence in anesthesia and surgery trainees and nurses with this curriculum. And the third aim is to identify strengths and areas for improvement for the curriculum. The overall goal is emotional intelligence awareness for better understanding of each other's perspectives. Here we get people together in the perioperative setting who are nurses, residents from surgery, as well as anesthesia. We present a real life case scenario, and then we discuss tools from emotional intelligence websites to regulate how we feel about that situation and how we would conduct ourselves. The focus is on self-awareness. So there's an emotional awareness, accurate self-assessment of how we feel, labeling the emotions that are felt in that situation. Usually these are situations causing some sort of conflict or strife within the perioperative working environment. Then we talk about the social integration. So we talk about awareness of the empathy, organizational awareness, service orientation. We talk about self-management or self-control at this situation, transparency, adaptability, achievement, initiation, and then relationship management. How do we manage our relationships? How do we discuss the situation with each other? Do we conduct it as a conflict, or do we conduct it in a conciliatory term? So we look at inspirational leadership from other examples. We talk about the change catalysts amongst us, and we discuss how we could build bonds and how we could do teamwork and collaborate in the future. In this painting that I found on the internet, I always use it in these modules. You can see the different perspectives. You can see a man being crushed by a boulder and he's trying to help a woman. He can see this woman not helping herself by holding onto the ledge, but he cannot see the serpent in the ledge that's hiding and will bite her, but she can see it. And she's not seeing the boulder crushing the man. So we don't see each other's burdens that we are carrying. And in order to understand the perspective of the other person, you must try and see the person from their shoes and try and walk the mile in their shoes. The other aspect of research that we are conducting is unconscious bias in healthcare. We're especially looking for unconscious bias in end-of-life care in the ICU. This is in collaboration with CARE and Insight Core, which are data banks and healthcare delivery sciences within Beth Israel. And all patients who died in the ICU are included in the past 2 years, who have a DNR order during their admission. The aims of this study are to find disparities in end of life care in the ICU based on ethnicity of the patient. And these will include the following scenarios. We will examine the patient factors leading to DNR and comfort measures only decisions in the ICU. We'll examine the processes involved in end of life care in the ICU using a validated quality of death tool. We'll examine the physician and team factors involved in DNR and CMO decisions in the ICU and their interaction with families, and assess family involvement in these decisions. We'll also assess appropriateness of analgesia during the comfort measures and provide baseline data for further interventional studies addressing unconscious bias in end of life decision making during the care in the ICU. So, in conclusion, this kindness research focuses on compassion moving forward, understanding compassion, based on the framework of where compassion comes from, the historical background, understanding what we are as physicians, as underlined by our history, and taking that in the future in our research. And as the president and CEO of the Beth Israel Lehi Healthcare System said, as an organization, our every day is rooted in healing and compassion, which means that we need to take on the challenges of systemic racism, bias, and injustice with passion and conviction. And he said, we can, we are, and we will. So with that, I'll end my talk and I'm open to questions. Thank you so much.